they will be telling their story a little bit later. But for right now, why don't we start with Dr. Sam Cheshire. Doctor, thank you so much for joining us. We're here today to talk about this intraoperative MRI, which you're now using at Primary Children's Hospital. So maybe just take us through, what this is and kind of how it's changing the way you do healthcare on kids.
So the intraoperative MRI is exactly what the name implies. It's an MRI machine that is directly in the operating room. This is a huge advantage for a neurosurgeon because it helps us understand the anatomy of the brain in real time. As we're operating on the brain, we're actually not exposing the entire brain during the procedure. We're exposing only a very small window of the brain. And as you know, pathologies in the brain exist next to structures which we don't want to touch at all. So, and as we deal with the pathology, the anatomy changes because the brain shifts around because the mass is no longer there. So being able to update our anatomy and by having the MRI directly in the operating room greatly assists us in increasing the safety of the operation and the success of the operation, because we can now make sure that we remove out all the tumors safely before leaving the operating room.
All right, thank you, Doctor. And next we are going to introduce Heidi and Olivia. They're joining us from Idaho Falls. Olivia was recently a patient of Dr. Cheshire's back in October when it was discovered that she had a tumor on her brainstem. And so Heidi, thank you so much for joining us today. And do you maybe just want to start from the beginning and kind of tell us your story of kind of how you started to realize something was wrong, and just take us through the steps of what brought you to Primary Children's?
Sure. So Olivia had been experiencing headaches for probably, 3 to 6 months prior. They're sporadic. But as time went on, I would say the last few weeks, they were really, really intense. Like, it got to the point it was every day, all day long. And then she started getting dizzy and throwing up. And so that's when, like, your instincts as a parent kick in, and I knew that something was wrong. And so we went to the ER here in Idaho Falls, and they were really proactive, and they did the CT scan and the MRI, and then obviously they recommended that we go to Primary Children's immediately. So they did life flight us the same day that we went in.
And tell us a little bit just how long did the surgery take? What was just kind of your initial thoughts as a mom when you hear a diagnosis like that?
Well, as a parent, it's frightening to get a diagnosis like that, especially where you don't think that something that drastic is going to be wrong. But we're so thankful that every technology that they have available was able to be used to treat her in that moment.
And Olivia, how are you doing today?
Good.
Mom, what kind of have you noticed just from where she was to where she is now?
She's doing really, really well. You wouldn't even honestly like to look at her walk, and you wouldn't know anything is like she walks great. She doesn't complain of headaches anymore. She's more energetic. She's back to herself.
That is so great to hear. Thank you. And next we're going to introduce Dr. Robert Bolo. He is a neurosurgeon as well with U of U Health and Intermountain Primary Children's Hospital. Dr. Bolo, take us through, because one of the procedures you do isn't just about removing tumors, but you also deal with a lot of children that have overactive brains, tend to have a lot of seizures. Can you tell us a little bit how you're using this new technology?
Yeah, thanks, Glenn, and it's nice to see everybody. We are committed, Dr. Cheshire and I and our entire group at Primary Children's, to using the most advanced technology available to treat any problem that requires or could benefit from surgery of the brain or spine in a child. And this is such a huge advance for us. And so about 1 to 2% of the population has seizures or continued, what we call epilepsy, which is ongoing seizures without a provocation or a cause. And about a third of those don't respond to medicine. So we think about medicines as being the primary treatment for seizures, but about a third of patients don't respond and continue to have seizures. And we're committed to having as many children as possible have as few seizures as possible and getting as many of them seizure-free as we can. And that sometimes involves escalating treatment beyond medicine to surgery. And when we think about those operations, they're scary, and we feel it's our responsibility, and we're committed to try to do them as minimally invasively as possible. So we use robotic technology coupled with something called laser ablation in the intraoperative MRI suite in order to treat areas deep within the brain sometimes, or in various locations throughout the brain with a laser that might be the source of the seizures to try to stop them. So what we often do is put probes or electrodes inside the brain to identify exactly where seizures are coming from using a robot. And when we identify them, we then replace that probe with a laser. And in the intraoperative MRI, while patient is getting scanned, we can heat up that area with the laser and watch it happen in real time and make sure it's safe. And I look at the rest of the brain all at once. And then oftentimes, we're able to successfully destroy that area. And then patients skip the ICU. They often go home the next day. They have one small, tiny incision we can close with one stitch. They go back to normal activity without restrictions. And so it's a game changer for sure. And we can contrast that to what we used to do, which is big operations, long stays in the hospital, multiple stays in the ICU, and a very, very challenging experience for families. Now with robotic laser technology taking advantage of the intraoperative MRI and doing laser surgery in real time in the intraoperative MRI, we're able to do minimally invasive surgical treatment and send kids home often, like I said, the next day.
And speaking of which, we actually have, and let me just quickly, hold on one second, let me share my screen here. Can you see that, Dr. Bello?
Yes.
Okay, great. So we're going to play this video, and if this is of one of your surgeries that you recently did, and if you can maybe just kind of walk us through, you explained of somewhat of what that was. Can you just explain the surgery process, what's going on, and then maybe some of the things you talked about will show up here, and just kind of tell us what's happening.
Well, this is initially us, our team, securing a laser in place after removing those probes to identify or listen to the brain where seizures are coming from. That's the patient. That's the robotic arm moving to the entry point. That's the scan where we uploaded the information we need to the robot to accurately and safely place the laser. I think in this case, we're treating a tumor, which we can also treat together with Dr. Cheshire using laser ablation. There's the robotic arm. We make a tiny little incision. That's the size of it. And we advance the laser through a tiny little incision. We essentially screw a small bolt into the skull and then advance the laser through that.
And that's the laser.
That is the laser. It goes in an outer tube that runs saline through it. And then this is the patient going in our intraoperative MRI suite into the magnet. Magnet being the MRI.
And tell me what's unique about this process, because you can't have a lot of metal there, correct? It has to be specialized.
Yeah, everything has to be specialized. We have to use special equipment in the operating room and do special timeouts to make sure that everything is safe. So there's the laser in place. And what you saw there on the screen that was gold was what we were able to treat with the laser on the screen. But that's the heat map with green showing where we're heating up the region of interest. And then we have able to toggle that screen back and forth and able to identify what we've treated. And then we can put safety markers all around the structures we want to treat that automatically trip the laser so it stops if there's any risk to surrounding structures. So that's what that video shows. Thank you for sharing that.
Yeah, absolutely. Thank you for sharing that story. And now we're going to open it up to questions. So members of the media, if you have any questions for anyone here, please put your name, the organization you're with in the chat, and also your question, and then we'll get those answered. One of the first questions we have for Dr. Cheshire, tell us a little bit about why iMRI isn't more readily available. Why is it unique that Primaries is the only one in the Intermountain West with this?
Well, having an MRI in the operating room requires a lot of infrastructure needs that the institution must have. First of all, you have to have a big enough patient load to justify having the machine there. And we're one of the top pediatric neurosurgery programs in the whole United States and have some of the highest epilepsy and tumor volumes in the United States. So from that standpoint, we can certainly justify having the iMRI there. Furthermore, the institution has to be of high level enough to have the appropriate support staff and ancillary services that could handle that piece of technology. You have to have top-notch neuroradiologists, pediatric neuroradiologists specifically, top-notch OR staff, and as well as top-notch neurosurgeons in order for the whole process to work together. I mean, even the information technology side of it is important. And because we have all those pieces necessary at Primaries Children, it became very doable for us to have an iMRI. And our operating room was positioned in such a self that to make it very optimal for us to put one in at a point where it's just connected to the neurosurgery suite, so that the scans are from OR to the scan is just one seamless procedure.
And tell us a little bit, because Olivia, you said, was your first patient that you used this new system with. How, Dr. Bolo talked a little bit about how in some of his cases, they've been able to be less invasive. For you, is this also less invasive, or are there other benefits, like with Olivia's case, where, you maybe see a faster recovery time?
Yeah, I would say that the better we understand the anatomy, the less we're going to manipulate normal tissue. And anytime that we're manipulating normal tissue, the less invasive it is. I can tell you, Dr. Bola does the least invasive with his with the laser surgeries, and the he's using a lightsaber to treat your pathology, and those incisions are less than a centimeter long. But even in the context of the craniotomy, if I can expose less normal brain, it's always going to be less invasive and lead to better recovery times. Olivia's tumor was fortunately what we call a low-grade tumor. It was a big giant tumor that needed to come out and was causing problems, but it's a low-grade tumor. And a low-grade tumor often looks just like normal brain when you're in there. And for her, I was very excited to have the iMRI because I knew that I can get all of her tumor out by having the iMRI in there to update to update this the anatomy. I remember her case clearly because I thought I had it all out, but again, it looks the tumor can look just like normal tissue. So we got the updated scan, took her back to the operating room, and I knew exactly where that tissue was to take it out. And the post-op MRI scan did not demonstrate any evidence of tumor. So I was super happy to have that on her because I didn't have to, we did it all in one. We didn't have to take her back the next day to take the rest of it out.
And when you saw from that video, does the tumor come up as a different color? How do you know when you have it all out?
Yeah, on the images, the tumor looks different than normal brain, and the computer algorithms make it a different color. So that's exactly what we're looking for. We're looking for the different color of the tumor relative to normal brain.
And Heidi and Olivia, just, I mean, when you hear something like that about how high tech the system was, and that you hear that they got it all out the first time, what's just your reaction as a mom and a patient, just when you hear that's everything that they were using to help your daughter?
We're just so thankful that, we had Dr. Cheshire. First of all, he was just amazing, but the technology was, that's great as well. We want, yeah, anything that we can do to help her out, I guess. What would are you just thankful too?
Olivia, what activities are you most looking forward to getting back to that you've missed out on?
Soccer, art, more stuff,
Playing with your friends and
playing with my friends, I guess.
Nice. And again, to members of the media, if you have any questions, please just put them in the chat. We will get those answered for you. Dr. Bolo, you talked a little bit about how you've used this with people who have seizures that don't respond to medications. You also can use them to take out tumors or to treat tumors. Do you see this as something that you're going to use a lot more often, or is it still going to be very specialized?
Thanks, Glenn. I think that Dr. Cheshire would agree that it's already changed the way we do things in our practice. And if we have technology we can, use in the operating room or bring to bear to help a patient, we're going to do that. And this just represents a commitment by our team in the hospital to use whatever tool is available, whatever high technology tool we can to help kids. And so it's already significantly changed our practice. We did some laser surgeries before we had the intraoperative MRI at Primary Children's. We had to go to the University of Utah to do it. That was really challenging and difficult, and it was often a huge delay between the time that we knew what we needed to do and the time we had access to that scanner. We didn't have dedicated pediatric anesthesiologists, dedicated pediatric neuroradiologists, our dedicated pediatric neurosurgery operating team, all of which Dr. Cheshire so eloquently mentioned. And I just want to underscore that. Now we do it all in our hospital with our team, with our staff, and it's all coordinated. And it's so much better. So I think it's already been a game changer in terms of how we work every day in the operating room. And I think its use will only continue. This is not something we're using occasionally. This is something we're using all the time, whenever we think it might have a role. And it's terrific.
And this is a question for both the doctors, and maybe Dr. Bolo, you can answer first. But you had mentioned that you sometimes were able to go to the U for special cases when it was needed. Why is it important to have that specialty in pediatrics when you're doing surgery? Can you maybe explain how kids aren't just little adults that, have everything the same? Can you maybe explain to the audience why it is having that people who specify in pediatrics in your operating room, in the iMRI room, why that's important to the successful outcome and why it's different than adult hospitals?
Well, thanks, Glenn. I'd also love to hear Dr. Cheshire's thoughts, but from my standpoint, while we want to bring every tool, every technology we can to bear to help your child, and we're very excited to do that, and we want to continue to push the envelope and bring more and more high technology tools. That's sort of what neurosurgery is and how it's changing, and it's very exciting to be a part of and to see outcomes improve while hospital stays get better and our incisions get smaller. But our job is also to stack the deck for safety and to have a whole team surrounding us that's dedicated to the care of children, to have a pediatric ICU should we need it right next door, to have a team of OR nurses that routinely takes care of children, to have pediatric anesthesiologists, a whole team of them in the operating room with us all the time. Children have smaller blood volumes. Their surgeries are by nature higher risk. They have all sorts of special considerations that make them not small adults. They have a dynamic or a changing nervous system. That's what we're intervening on. And that's very different than a full-grown mature adult. right? A child is growing, and a 1-year-old's different than a 2-year-old, than a 5-year-old, than a 10-year-old. And our whole team, our whole hospital, our whole operating room is designed to identify those issues and critically address them and take care of them to help kids. And so it's very important to have it in the children's hospital. Dr. Cheshire, do you have any thoughts?
First of all, I agree with everything Dr. Bolo said. Children are different than adults. They have different physiologies. They require different medicines. They require different equipment, both on the anesthesiology side and on the neurosurgical side. And having people who do that every day, including the OR staff, I mean, we get handed off different instruments that we use during the course of the operation. Our staff knows that. The staff at the U didn't necessarily know that. So having the people there who always do kids, anesthesia, OR, neurosurgery, that's all, and neuroradiology especially, because the tumors and the pathology in kids are very different than the tumors and pathology in adults. So it's very important to have it be pediatric focus and pediatric specialist. About a month ago, Dr. Bolo and I used the iMRI on a child that was only 3 months old. We took out a very large brain tumor in the exact center of the brain, right on top of the brainstem. We got it out successfully, and the child is doing very well. But there's absolutely no way we could have done that using the adult scanner on the adult side. I mean, they're very good at what they do there, and we were honored to be able to work with them when we didn't have the particular technology here. But now that we have the technology here, boy, we can really use it on even on real babies.
Well, that is definitely amazing. And so I'm not seeing any more questions from our media partners. So I just want to end by thanking everyone for joining us today, Dr. Bolo, Dr. Cheshire, and Heidi and Olivia up in Idaho Falls. We appreciate you joining us. To members of the media, we will be sending out a recording of this press event, and we will also include a link to a media packet, which will include some pictures. And also, we'll have a longer version of the video that we showed you during this press conference. So you can use that for editing and some B-roll. And we'll also have some still photos that you can use for any print or web. I just want to thank everyone for joining us today, and everyone can have a great day. Thank you.
Thank you.
Thanks, Glenn.